Now I invite Dr. Purvi Bhagat. She is a professor and head of the department in the Western Regional MNJ Institute of Ophthalmology. Yesterday only she received the honorary FACO uh, award, and in the next session she is going to get the International Heroes Award. So
Thank you, madam. Thank you, and thank you, Dr. Mayuri, madam, for including me in this IC, and of course to AIOC for considering this IC in this prestigious event. So what I'll be talking on is kind of basically going to be an overview, somewhat an overlap, and a summary of the entire session that has been discussed, and a little something beyond that. So it will be considering what is the present day status of anterior segment imaging in glaucoma practice. So if you are looking for more amount of objectivity, because that is what we heard from Dr. Sood sir, that gonioscopy, one of the limitations is it is a subjective test. So if you are looking for more amount of objectivity with a reproducibility, you are looking for different measurements with great precision, you are looking for calculations, and if you are looking for practicing teleophthalmology, telemedicine, storage of data, use of softwares, then anterior segment imaging is the way to go. You may have cases like this. Significant corneal edema, gonioscopy, of course, is not going to play any role here. So here, anterior segment imaging, as we have seen, plays an important role. It tells you whether it is just a pupillary block with iris bombay, convex iris configuration, or it is actually a synovial closure. In different kinds of occludability also, you can see these different types of iris insertion. So that will also help you in clinical decision making, the diagnosis, and whether you want to do a PI for this patient or not. It also helps in the darkroom provocative test. Again, you have seen an occludable angle on gonioscopy. You are not very sure whether you want to do a PI for this patient or not. So you can do the tests, either it could be ASOCT or it could be UBM, under lighted conditions and under dark conditions, and you can see how the configuration changes. So this is not only helpful for you in the clinical decision making that yes, this patient needs a PI, but it also helps in patient education, because these kinds of imaging, when you show to the images you show to the patient, it's very easy to counsel them and show them that if you don't undergo PI, you might land up in an emergency. Cases like this, it's very easy to confirm that the PI is patent. It's a very mid-peripheral and a large PI, there's no doubt about it. But when you do the gonioscopy, sometimes you are not very sure how much the angles have actually opened up. So that quantification of your success which you are looking for is missing. So here, biometry with the AS imaging plays an important role. You can do different calculations. You can produce reproducible criteria. You can document change either longitudinally over time or with your treatment, and you can again identify the at-risk population in whom you would want to do some interventions. Cases like this, there is a PI but hidden under the dark arcus senilis. You are not sure whether it is patent or not. So you do an imaging technique, and it could be again OCT or UBM, and you can see very well how it is nicely patent here, but here there is still an iris tissue left which needs to be perforated. Lens volt, again very important. You will see this volcano type of a sign or a Mount Fuji sign on gonioscopy, and you measure the lens thickness and the lens volt. That is the distance of the anterior pole of the lens from this horizontal line joining the two scleral spurs. So this will tell you whether the lens is actually playing an important role in the angle closure and its removal will help or not. For example, these cases AC is very shallow, the lens volt is very high, and in these cases, if you do the lens extraction, of course, the entire scenario and anatomy will change. But on the other hand, if the lens volt is not significant, you can see here the angles are already open, the lens volt is not significant. So in these cases, if you consider that your lens removal is going to help, you are making a wrong decision. Again, pigment dispersion, not very difficult to diagnose on gonioscopy. You will see the sample line, you will see the mascara line on the trabecular meshwork or concave iris configuration. But sometimes imaging helps in additional information. You can see here a very concave iris configuration. You can see the iridolenticular touch, and here even it's in touch with the zonules. It's not visible on screen, but the zonular fibers are there. So basically it's in touch with the zonules and the lens. So PI is always a dilemma and a debate whether it should be done in pigment dispersion syndrome. But in these cases, if you do a PI, it definitely helps to reverse the entire anatomical configuration. So it helps to halt the progress of the condition. You can see how the entire anatomy has changed. Again, cases like this, UBM plays a very important role. Post-trauma, you can see those cyclodialysis clefts. Sometimes post-trabeculectomy also. You have unexplained hypotony post-surgery, and you do a UBM and you can see those clefts which can explain the condition. Sometimes on gonioscopy, you can just see synechia formation, but when you do an imaging, you can find that behind that synechia, there could be angle recessions or cyclodialysis. Foreign body is again very important. It will help you to determine your mode of treatment, how to approach that foreign body, what tissues it is traumatizing, and how to manage the case. An added advantage of UBM is cases of pseudoexfoliation. You can see all those dandruff-like material over the zonules everywhere. And here you can see this laxity of the zonules also, and you can see these broken zonules. So if you're planning for cataract surgery in these cases, all these investigations and images, they help you to manage and prepare your case accordingly. A case of subluxation of the lens, you can see how grossly it is subluxated. It's a large lens and totally closed angle on one side. And sometimes in spherophakia, you can even do the biometry. So it will help you to diagnose whether what type of a lens it is, and again manage a cataract surgery accordingly. Malignant glaucoma, again UBM plays an important role. If it is a case of malignant glaucoma, it will be totally everything is flat and shut down. There will be no sulcus, no posterior chamber formation. Whereas if it was a case of simple pupillary block, you can see the presence of the posterior chamber. You do a gonioscopy, you can sometimes see these peripheral humps, you can see lumps, elevations. So you are almost sure that there is something behind the iris there which is causing these elevations. So you do the UBM and you can see how anteriorly rotated these ciliary bodies are, which is causing those peripheral hump formations. So a typical case of plateau iris. Or sometimes there could be cysts, masses, or tumors behind the iris, which are causing those peripheral humps. So these are cases of pseudoplateau iris. In these cases, again, imaging helps to know the origin, from where it is arising, what is the content. Here you can see it's a cystic formation, and here you can see these are melanomas. You can see the extent and whether it is progressing or regressing over time or with treatment. Functional status of the bleb we have just seen. In addition, imaging, it helps you to decide where you should take your compression sutures in overfiltering blebs, which blebs are likely to be more responsive for needling, to evaluate your bleb changes after suture modifications, either lysis or release or adjustment, and in planning of bleb revision surgeries. We do a lot of shunts and tubes now, so sometimes on slit lamps it is difficult to gauge whether it's actually touching the cornea or the iris. So when you take a cross section with these imaging techniques, it actually helps to clarify whether it is actually touching any of the tissues, and any modification of the tube placement needs to be done. Coming now to the newer advances that are there in the present day, we now have the swept source OCT, which allows a three-dimensional 360-degree analysis of the entire angle, and it is very, very helpful for, again, patient education and for clinical decision making, and all these structures are visualized in a very high resolution. An added advantage of swept source OCT is that it has a great amount of reproducibility and objectivity, and it allows you to measure the iris trabecular index, which is actually a measure of the extent of angle closure, and also identify the peripheral anterior synechia. For example, this red line is depicted as the scleral spur. So anything that lies above shows the area of contact. So here you can see the entire angle, everything is above that scleral spur, and you can see this blue zone. It again depicts the amount of iridotrabecular contact. So here it's a 100% closed angle, whereas here there are just isolated elevations which shows some amount of iridotrabecular contact. So this is a very major advantage of the swept source OCT. We also now have the ICAM, which is a gonioscopy assisted imaging, which also allows three-dimensional, very high resolution, high magnification, true color view images of the entire angle. So small and fine things like pigmentation, neovascularization, small synechia, which can otherwise not be picked up in the conventional ASOCT, can be picked up with the ICAM. You can also do the surface imaging like Schlemm-Flug imaging, scanning slit lamp systems, in vivo confocal microscopy, where you can have very high resolution images of the anterior chamber and mainly of the cornea. So if you're planning for refractive and cataract surgery in glaucoma patients, in pseudo-exfoliation, you want to study the effect of drugs in these eye, you want to see whether your trab is going to be affected by any surface changes, then you can do these surface imaging techniques. But these are not effective for angle imaging or beyond. This is just mainly for the cornea. Everything now in the field of investigations is associated with the AI developments. So even in AIOS2025, AI-assisted techniques are now there which can actually assess or improve the image quality that you have received. They help in image classification and analysis. We have seen in the first lecture, those who were present, that scleral spur is the key anatomical landmark which helps you to define angle closure and do all the biometry of the angle. But the manual annotation of scleral spur is very difficult. It is subjective, it is time consuming, and sometimes may not be possible also, especially if there is angle closure, synechias and all those things. So now AI incorporated in the AIOS2025 helps you to actually objectively detect the scleral spur and do all the calculations. AI can also help you to predict the efficacy of laser PI in angle closure suspects. So it will actually tell you how the angle is going to change over time, just like you have the VFI in Humphrey fields. It actually helps you to understand how the angles will progress over time, do a trend-based analysis, and whether doing a PI will make any changes. So it helps you to optimize the patient selection and also avoid any unnecessary interventions. So to conclude, if you are looking for sensitivity in angle closure and study angle closure in details, OCT has better results. But if you are looking for the greatest range of anatomical information, study the ciliary body, study the lens well, study the zonules, then UBM is the way to go. So AIOS2025 definitely improves diagnostic accuracy and treatment planning. With AI now incorporated into anterior segment imagings, angle analysis is very convenient, very feasible and objective. And if you combine multiple modes of investigations, gonioscopy, OCT and or UBM and or Schlemflug imaging, then it will definitely give you a more comprehensive understanding of angle dynamics as well as the overall glaucoma pathophysiology. Thank you.
Thank you, Purvi, for summarizing the whole session. Any questions from the audience? We can take it now for anybody. Yes, sir.
What is the cutoff of the lens wall when you consider the patient for cataract surgery?
Purvi, would you like to say?
Actually, there is no cutoff. It is an individual measurement, and it basically just tells you how much the lens protrudes into the anterior chamber. So basically, it's a subjective evaluation. You just calculate and see whether it is contributing to the angle closure component or not.
Okay. And what about the mix mechanism? Sometimes when we see the lens vault is also there and there is a pupillary block mechanism is there. So should we go for the PI first and then decide, or like how you approach this?
Overall, most of the glaucoma specialists feel that every eye of angle closure does have some element of pupillary block. So the first step would be doing a PI. After that, you re-evaluate, repeat the imaging, repeat the gonioscopy, repeat the IOP. If you feel that the lens vault is significant, then you can go for cataract surgery. And of course, if the trabecular meshwork has been already damaged beyond repair and there is a true mixed mechanism type of a glaucoma, then you would treat it as an open angle glaucoma and proceed likewise. So it has to be a stepwise algorithm that you need to follow.
By doing the laser PI, you can also prophylactically prevent the malignant glaucoma after cataract surgery. So that may be of help.